And so I would really encourage the audience that even though it's great and a huge time saver and it is up to date on steroids, make sure you check your work. There still needs to be a human at the wheel. We are ultimately responsible for the care of our patients, and we shouldn't accept these things in their very earliest iterations on blind faith. We are still dealing with kind of the Fisher-Price version of AI at this point, and it's going to change drastically in the next 2 years.
Hello, everyone. My name is Kevin Bambury, and I welcome you to another episode of Oncology Spotlight. Thank you for tuning in. Our guest for this episode is Dr. Douglas Flora, who is an executive medical director at St. Elizabeth's Healthcare in Kentucky and an editor-in-chief of AI and Precision Oncology Journal. Thank you very much for joining us today, Dr. Flora. Could you briefly introduce yourself to kick things off?
Yeah, hi. Thanks for having me, Kevin. My name is Doug Flora. I'm a practicing cancer doctor here just outside of Cincinnati, Ohio. We have the privilege of helping run the Young Family Cancer Center here at St. Elizabeth.
Brilliant. And can you tell us a little bit about your background and what inspired you to a career in medicine?
I've been pre-med since I was about 5, so I can't go back too much further than that. But I can tell you I had a definite inflection point when my family lost my mother to breast cancer. She was diagnosed in her late 30s, and it didn't go well. So certainly that was very informative. My brother and I are both partners downstairs, taking care of cancer patients, and I spent the majority of my professional life caring for breast cancer.
Brilliant. You're editor-in-chief of the AI in Precision Oncology Journal. Can you tell us a little bit about, what's the biggest challenge in bringing AI from research labs into frontline cancer care?
Oh, good question. The reason that we started this journal was exactly that. I felt like there was a ton of hype and a lot of vendor conversations, and many of them are completely legit, but that the physicians weren't keeping pace. And so I wanted there to be a repository of trustable, verified, peer-reviewed manuscripts for us to review with the same level of, critique, as we do regular data on drugs. And I wanted to start a journal where we could democratize these technologies in a way that you could trust that it had been content that was curated by people that were probably a couple years ahead, people with informatics training, and people who are really caring about the same things that I cared about as a doctor.
Of course. Excellent. And have you seen anything so far, any tangible benefits to your clinical practice as a result of AI? Is there any examples of stuff that you're
for me, it's a huge time saver. I've gotten rid of a lot of the rote mechanical things that plagued my normal life, like emails and a lot of my documentation, a lot of my prior authorization notes to the payers here that we have to argue sometimes for the standards of care. Certainly lots of things like letters of recommendation for people who work for me or trainees or those sorts of things. So very, very simple at that point. I use them a lot for my own research to understand some of the diseases I care for. Started to dip our toes into clinical decision support and management of things like navigation and the tumor registries, things like that as well.
Yeah. Could you give me an example of some of the solutions you're using, like some of the names of the brands, etc.?
Sure. Well, we're an Epic shop, and so a lot of these tools have been proffered by Epic in their early iterations. They have a deep partnership with Microsoft, so we use Microsoft Copilot here. We have a lot of third-party software that we've looked at and are evaluating for things like clinical trial registry. We just had a company in our auditorium today that was pitching to a lot of our leadership about how to manage some of these other business practices. And then in my personal life, I live on them. Everything that I do is done on Gemini or Perplexity or Claude 4.0 or OpenAI's GPT-4 Omni, and I move back and forth depending on the individual use cases.
Okay. And can you tell us, is Gemini best for some things while ChatGPT is better for another? Or like how do you decide what to use where?
I think they tend to leapfrog each other, right? Each iteration improves on the one before. And for all of them, the premium models are similar-ish, and I'll describe some differences. And the one that was just made free is better than the last premium model. So Claude 4.0 is now $20 a month, whereas Claude 3.7 is now free. And Claude 3.7 used to be the $20 a month version. Do you follow? So I enjoy Claude is very good for coding. Claude is very good for natural writing. I find that deep research on GPT-4 is fantastic. Perplexity as well, if I'm looking up things, whereas I used to use search engines, now I use Perplexity instead of Googling. And then I'd say probably my overall backbone of what I do is on Gemini, because it has such a enormous context window that it remembers everything I've ever given it, which it's starting to understand my voice and who I am and what I care about.
Yeah. And speaking of voice, what percentage of your work is done through voice versus typing?
Fair question. 50-50. I do a lot in the car. That's I have a self-driving car. I try and be efficient, but I still have to keep a hand near the wheel or on the wheel. And so most of my stuff for my commute is definitely spoken in. The longer prompts that I'm building, if I do a 3/4 page prompt, I'm a horrible typist, so I'll do that by voice. If I'm sedentary, seated at my desk, and I have a defined task that I could iterate with a prompt, I'm still typing those.
Okay, brilliant. So we have a lot of different clinicians from around the world, who tune into our podcasts. I'd love to know, is there any 3 tips or 2 or 3 things they can do that, 3 hacks maybe that you have been using that you find have helped improve your productivity in the clinic that maybe they could adopt?
Yeah, I think obviously the biggest one that's pushing its way into our lives in a great way is all of the ambient scribes. There are probably 7 different companies out there that are vying for this market, and all of them work great. I've seen 3 or 4 of them in action in person. This is a Microsoft shop, so we would have the nuanced stacks being piloted with our physicians. But essentially, for the providers who aren't aware, this is run through your phone. It sits in your room. Your entire conversation takes place with your patient and their family. And then the deep learning modules understand what is germane to your visit and what is personal. And so it takes out the conversations about how was your vacation or did you get to see your daughter in California? And it knows that I need the subjective objective assessment plan. And so those are being very, very useful. I know my friend Deborah Pat, who runs Texas Oncology, is one of their chief officers. They have, I think, 1,008 oncologists on one of the scribes, and it's been accepted with a great enthusiasm by the providers. Some of the tools have reported that they give time back. Some haven't, and I think that comes down to how efficient you were doing your notes and how efficient you are learning to use these tools. And so I think we'll see lots of time savings in the next year or 2 as these things become more accepted and acceptable.
Okay, brilliant. Just thinking about AI tools and ethics, is there anything around, is there anything people should be aware of when it comes to patient data and decision making? Yeah. How do you manage that?
Well, definitely. And that's a big concern. This is something we publish on in our journal quite a bit. We've had a lot of ethical articles, and it's really critical that the providers and the physicians understand that these tools really require us to address safety just like the drugs do. And we need to understand what data was used to make decisions. Were these data sets that were provided to these tools biased? Do they include Black or brown people or people from Appalachian Midwest? Because they may have different diseases. Obviously, in cancer medicine, we know there's a huge difference between a 48-year-old man, Black man with prostate cancer, whose dad had prostate cancer, and a 79-year-old white man. And so I really want to make sure that before we move heavily into clinical decision support, that the physicians that are listening understand the terminology, understand how to vet these things responsibly and critically, just like we would any other tool that we add to our armamentarium.
Yeah. Okay, great. And speaking of decision support, is there anything you're doing at present in terms of decision support, like day to day with AI?
Lots of oncologists are. My center's been a little bit slower to adopt that. We're still in the really, really being careful about data governance. As you know, there are 18 pieces of patient health information that we cannot share. And these things in Gemini or OpenAI are recorded and used to train their modules, their deep learning modules. So we are still in those evaluatory phases where we have a technologies committee, we have an AI steering group, and we're working through those and instrumenting the tools that we feel are safest and have the greatest level of benefit with the least level of disruption. I'm not 100% sure we're there yet on all clinical decision support. And part of that is that it's still a bit of a black box. And until it's truly explainable AI, it's harder for us to accept it as doctors. Until, as the programmer, understand how these transformers are coming up with the right answer, or if it is the right answer and you can show your work, physicians are going to be very circumspect about that and should.
Yeah, of course, of course. Something like Open Evidence, I believe, has links where it shows its references and where it's sourcing its data from.
Exactly.
So I believe
I like that for the deep research function on the OpenAI tool. Gemini's got a lot better at that. Perplexity, I love to search things, but I have found a lot of hallucinations in the references. So it will cite for me, and then I go to that reference and it's fabricated. And so I would really encourage the audience that even though it's great and a huge time saver and it is up to date on steroids, make sure you check your work. There still needs to be a human at the wheel. We are ultimately responsible for the care of our patients, and we shouldn't accept these things in their very earliest iterations on blind faith. We are still dealing with kind of the Fisher-Price version of AI at this point, and it's going to change drastically in the next 2 years.
Excellent. Okay. You're a cancer survivor, or research shows. And how does that approach the way you treat patients and leadership today?
That's become very central to who I am. I hope it was before. We've always said here at St. Elizabeth that we put the patient in the center of every discussion we do. I would say my empathy deepened for the smaller things, like how hard it is to wait for a CT scan result, because your whole life could be changed. So I had a patient just texted me this morning. I tell them, when you roll off the CAT scanner, send me a text on my cell phone to let me know that it's out there, so I know to look for it, so I can get you a result within an hour. I used to think a day was soon enough for that, and now I want it in minutes. Good or bad news.
Yeah.
The worst part is just waiting and wondering. So that was informed by being a patient. I've also looked for a lot of efficiencies here. Having gone through the patient journey, I'm very eager to introduce tools that will improve the patient's experience, whether it will be getting into the office or triage or what happens once you arrive at the office. I really want to make this a seamless experience and not a bunch of silos.
Yeah, of course. You're a vocal advocate for the whole person care. How does that philosophy change how you treat patients day to day? Can you explain a little bit more about it and how that works?
Sure. Well, Kevin, I'm sure the physicians where you live have adapted lately. But as I came up, it was very patriarchal. It was, almost, and these people are fantastic doctors and my mentors, so I'm not disparaging, but they had limited access to data and they had to make really important life and death decisions, oftentimes with less information that would make them comfortable. And so a lot of times what we end up focusing on was, are you safe and appropriate for today's chemotherapy dose? Is your scan good or bad? Those are important, but that's not the entirety of the patient's experience. And so a lot of times we fail to get into things like existential dread or financial disease or how do I tell my kid I have cancer? And I find that those are sometimes the most meaningful visits I have, is when I step back a little bit and I remember that the patient also has an agenda in this 30-minute slot. It's not just about what I want to get out of this visit, so I can document on my note, so I can write the chemotherapy or immunotherapy's dose. They have completely different issues that are running through their minds. And it might be, am I going to get to my daughter's wedding in June? I found as a better listener, we care more about the whole person and not necessarily just about the chemotherapies. And I would say that's a generational thing too. I find that that's much, much more common in physicians who are in their late 30s or early 40s. I'm now 53, almost 54. And I see that happening very commonly now. I'm proud of that.
Brilliant. That's great to hear. So going back to AI, what do you believe will be the most disruptive AI development in oncology in the next 5 years?
I could tell you my hope, and I really do believe that we're almost there, and that's early cancer detection. We understand physiology quite well now. We understand the building blocks of cancer, and we've sort of dissected the code of life now. With the stuff that happened with the protein unfolding that was awarded the Nobel Prize in Chemistry in October, we really now can predict a lot of things that we couldn't in terms of drug development and drug design. So those two things are exciting for me. Both of them are based upon the same molecular understanding of tumors. If it's early cancer detection and multi-cancer early detection, we're using AI to detect and discern patterns to separate cell-free DNA from ctDNA that's elaborated by tumors. Hopefully getting to the point that instead of doing single organ genetic or a single organ screening like a colonoscopy or a CT scan for the chest or a mammogram, maybe we'll be looking for 40 or 50 or 60 different cancers from these whispers in the blood. The second part of that is designing drugs to counterbalance those mutations and attack the proteins at their own Achilles heel can be predicted now with these deep learning modules like DeepMind and AlphaFold. And I see a ton of industry people running rapidly towards a faster, smarter drug development, which excites me as well.
Excellent. So just thinking about the early detection, do you see a place where, every patient goes to their GP, they get a blood test, and, as part of that blood test, they're diagnosed then and there, with early stage cancer?
I don't think that's hyperbole. I think that it's not impossible to understand that in 15 or 20 years, every child comes out of the uterus and gets their heel pricked. And that helps us inform our decisions about how to care for that child, for what diseases he or she might ultimately have. We're not quite there yet, Kevin, with the multi-cancer early detection. We still need to refine the tools. There are claims being made that they're better than they are. Right now, still for the commercially available ones, you got to do 200 tests at great expense to find one real cancer and one false cancer. And that's probably not a great screening test. So we either need to test people more carefully, test in the high risk, a target rich environment, if you will, or we need to refine the test so that they're more sensitive and more specific. Because the worst thing I can do is identify something that isn't there. Now, I've terrified the patient. I probably ruined their chances to get life insurance. And generally, these tests don't pay for the follow-up examinations for a CT scan or a PET or an MRI. And what do I do if I have a positive ctDNA suggesting that the patient has cancer and I can't find it? Then I probably harm that patient's at risk emotionally and physically because I might chase a diagnosis that isn't even real.
I've heard that before. I've heard it discussed a lot. They call it, where you're looking for something, and if you look hard enough, you're going to find something, and it's counter. It ends up not being.
And the question is, are we screening the right people for the right diseases at the right time? And I would posit there are smarter ways to do that than just all of the population. We know that 88% of women are never going to develop breast cancer. They have 0% chance of developing breast cancer. Can we be smarter about detecting who those women might be who are at risk and do a better screening test? That makes a lot of sense to me instead of just old-fashioned, let's screen based upon age, because that's what we do. I would much rather use your whole body risk, your systems biology risk based upon where you live, what you breathe, what you eat, what you weigh, how much alcohol you drink, what your family history is like, what part of the country do you live in. All of these are part of a systems biology approach and can be incorporated into a polygenic risk score that would tell me that these 12 women have a very high risk. These 13 women have a moderate risk and should be screened. These other women have no chance of having the cancer based on these screening criteria. I'd like to think that we're going to get there in the next 10 years.
Brilliant. And thinking long term, 20 years from now, do you see a place where, there is a sentient, all-knowing AI specialized in oncology that can answer?
Yes, I do. Sentient, yes. All-knowing, all information gathering. They really don't have perspectives. They don't have context. They can't calculate things like, I want to make it to my daughter's wedding in June, right? That's not going to be part of the algorithm. And so I do think that what will happen is we will become more like guides to help them cure their diseases, hopefully eliminating late stage disease in the first place because of the tests that we've described and education about getting people easier screening. But say if you do have an advanced disease, I still think that there's a role for a human being in the room at all times. We need to check the computer's work, obviously. We need to understand the nuance and the context of the patient's disease. We have to be there to hold a hand. We have to be there to give them a hug. We have to understand if we're sharing too much bad news at once and that patient's not quite ready to receive that, even though I might be able to deliver it, maybe hold that back a little bit for the next visit. I don't see that. I think oncology might be one of the fields that is last on that list of things that the robots or the machine learning teams can replace.
Yeah. No, that makes sense. What kind of legacy do you hope to leave in oncology?
We talk a lot about this in my family. It's not just oncology. I really want to improve the global happiness index, as goofy as that sounds. And I can either do that by the people that I love, the people that I work with, the people that my family members, make the world a happier place, or we make it a less sad place. And so each day I wake up, I try and improve the global happiness index by affecting both of those things. I'm a very positive, very upbeat person. I'm a very positive, upbeat leader. Hopefully my team would recognize that. I'm upbeat for my patients and my family. And then I hope the people that surround me have some of that enthusiasm and energy to do the same. And I guess my legacy would be that I help a lot of people along in their diseases or their professional or personal developments that make them contribute to the GHI as a steady upstream effect.
Excellent. Excellent. And just kind of taking a step back, where did the interest in AI and oncology come from? Were you very interested in, smartphones, the internet, all of those kind of different stages, or is there something about AI that makes it?
Mine was frustration. It was frustration. I encountered so many mini crises, especially just before and after COVID, as we were seeing staffing crises and sort of the deterioration of the physician-patient relationship. And in the States, certainly the insurance companies became maybe not the highest advocate for patient care. And a lot of those things led me to find solutions. And in those solutions, I looked for tech to augment my ability to make good decisions and augment my staff so that they didn't have to spend all day fighting for things like prior authorization from a payer. Or if we didn't have staff, how do I get that critical job done for the patient? And I started to lean into this and I started to study it pretty heavily 5 or 6 years ago, right around the time this stuff blew up with telehealth over around COVID. And then as a tech aficionado, I read an awful lot. I took a bunch of classes at the MIT X course and other things. And I've been reading about it pretty much daily and nightly for 5 years now. And I'm glad I did because I do feel like there needs to be a physician at the table. And most of my partners are just so darn busy with patient care. They've got their heads down. They're surviving their days right now. And in an administrative role, I have a little bit more freedom in my schedule to try and make a difference and prevent the problems that continue to frustrate my doctors. And that's sort of where it started. Then it took on a life of its own when people started to ask what I thought. And I still find that to be a little surreal, but I did have a head start. And if I can manage it, anybody can manage it.
Great. Brilliant. Final question. What advice would you give to your younger self just entering the field of oncology?
I would say that the most meaningful thing that's kept me afloat in this really, really arduous field is my friendships, my networks of people that have become dear compatriots in this battle with me. My brother is one of them. Obviously, we're quite close, but my partners are phenomenal human beings. They have all been just a big part of what my life has become. At the same token, as I hit my mid 40s, I started getting involved in the national discussions. And I have found that there are some incredibly brilliant people out there trying their guts out to try and make cancer care better. People at the American Cancer Society, people at the Association for Community Cancer Centers, the Community Oncology Alliance. And my network has grown over the last 20, 25 years to the point that now I feel like I can pick up the phone and ask advice from someone wiser than me all the time. And I'm so glad I invested in those authentic relationships because now that I'm the old guy, I can call somebody else who really knows with context what's going on and get an unfettered opinion. And for me, that really gives me peace of mind that I'm able to make better decisions because I can rely upon really smart people that are going through similar problems that I am here.
Brilliant. Thank you very much for your time, Dr. Flora. That was a very, very interesting conversation.
Thanks.
Greatly appreciate it.
I appreciate it.